medical emergencies. Right? So, based on your experience with clients, with research and things like that, are there specific situations whereby these breaking into houses that led to medical emergencies that you remember somebody in a very serious situation and it's almost like they're not going to make it and things like that? Any particular one that you remember?
Yeah. So what's funny about this is usually when people get into lipids or they get into preventive cardiology, it was because of some personal experience, And I wish there was some more humanitarian reason that I got into lipids, but really I was sitting there on a dark January day many years ago, and I had one of my patients cancel, and I'm always reading stuff. And I pull up this article, and the title was just something obnoxiously condescending, like basics of lipids and lipoproteins. And I'm like, okay,
Mhm.
I'm pretty good at biochemistry. How hard can this stuff be? And so I read this article, which was supposed to be a rudimentary review of cholesterol homeostasis, and I barely understood any of it, and it made me mad. And so I'm like, well, that's unacceptable since this is pretty important, and a lack of cholesterol is incompatible with life, but a cholesterol laden perpetrator in the wrong place at the wrong time
Yeah.
is going to lead to the cascade that results in a maladaptive immune response that can subsequently result in clinical events like heart attacks. And so I was like, okay, well, this is probably worth learning. And I'm going to try to learn everything there is about lipids. And what's amazing is you will inevitably fail when you try to learn everything about any topic. But in the process of failing, man, you can learn a lot of stuff. And then hopefully you can help some people along the way with all the stuff you've learned. So that's how I got into lipids. But there have been so many amazing things that have happened because I immersed myself into lipids because I was rankled about not understanding an article. And so one
Yeah.
of the stories, and this is a story I tell in chapter 6 of my book, which is about LP little a, which is the felon of the lipid neighborhood. And really, the reason why LP little a is, well, there are many reasons it's so nefarious, and we're still elucidating the specific pathophysiology of it, but it's an independent risk factor for cardiovascular disease, meaning you can have what looks like a fine lipid neighborhood, even your LDL cholesterol and your ApoB can be, quote, normal. But if you have elevated LP little a, you are still at heightened risk of having cardiovascular disease. And so one of my good friends, and so we actually met and we were running together. I was helping him train for the Boston Marathon actually and qualify for that. And we were out on a run at 5:30 in the morning, and I was talking about lipids, of course, because what else would you talk about at 5:30 in the morning on a run? And he starts telling me about his family history, and his family history was really pretty bad as far as people having cardiovascular disease. And I was like, huh. And I was like, well, have you gotten your LP little a checked? And have you gotten a CAC, that coronary artery calcium score? And the common question, and he's a medical professional himself, and he works in dermatology. And so he's like, well, what's that? And that's what I hear a lot of times is, what is that? What is a CAC? What is LP little a? Because these aren't, to this point, these haven't been traditionally taught in medical programs. And so I think the landscape is shifting there, though, thankfully. And so anyway, so we start talking about the LP little a, the felon of the lipid neighborhood, and CACs. And so he ended up going and getting this LP little a checked. Well, his LP little a was 128 milligrams per deciliter. And there are various ways to test for LP little a. The preferred way is nanomoles per liter, which gives you a particle count, and then milligrams per deciliter is mass. But regardless, 128 milligrams per deciliter is really high. And then he gets his CAC. And a CAC of 0 means that, hey, there hasn't any evidence of break-in as far as calcified plaque goes. And then conversely, a score of 300, you have equivalent risk of having a heart attack as people who have had prior heart attacks. And so his CAC was 2,814. 2,814. And he actually ended up having to have a 5-vessel coronary artery bypass graft because he had such extensive atherosclerosis. Now, that's an amazing story, but here's the deal. He had no other risk factors. He actually had no insulin resistance, even by my advanced standards, okay? Because most people are insulin resistant, which is not picked up on just your basic fasting glucose, A1C. And so he wasn't even insulin resistant by my standards. He didn't have hypertension. He had no systemic inflammation. So we had checked his HSCRP, which is a common marker of systemic inflammation. It was 0.4. So he was totally fine on that. And he had decided not to do drugs, which is good. And so this guy had a perfect home security system, and his LDL cholesterol was not remarkable at all. But he had this felon of the lipid neighborhood, and it had caused lots of problems and had committed serial crimes over the past decades, apparently. And so that is a good example of, hey, just knowing a couple of things, Lp(a) and CAC can help you identify somebody who would go undetected by our standard risk calculators, because a lot of times clinicians are taught to use a 10-year risk calculator. And now there's this new Prevent risk calculator, which is a 30-year risk calculator, which is, it does some good things as far as identifying a few more things than the standard 10-year risk calculator does. But those risk calculators miss a lot of people, unfortunately. His 10-year risk calculator was 2.3%, 2.3%, which is the low risk category. And you're told, hey, keep on doing what you're doing. You're good. Keep crushing it. But no, I mean, he probably wouldn't be alive if we hadn't gotten his Lp(a) checked and that CAC. And so I'm a big fan of being preventive and shifting the paradigm from reactionary to preventive when it comes to cardiovascular disease. And so that's a pretty remarkable story of just a couple different things that you can easily add in, whether you're a primary care clinician, whether you're a cardiologist, whether you're an endocrinologist, whoever you are, whether you're a patient who goes into your doctor and teaches your doctor about these things, which does happen if they're willing to listen. And then, hey, that's good, because we can identify things before they become problematic. And I'm really grateful that we were able to identify that. And what's really cool about this guy is it was last year, it was 2024 that he had his bypass graft. And then last year he was able to train and complete this half Ironman triathlon, and not only complete it, but he did so well that he actually qualified for the world championships for his age group in France. He didn't end up going and doing it because of other life obligations, but I mean, that's pretty awesome. So when those stories are continuing to be lived out, it's a neat thing, and hopefully it inspires people to get the itch and to catch the bug when it comes to prevention as well.
Good. Thank you for